Right, hello. Howard said, could I do sex and drugs and rock and roll? Is that, no, right? Yeah, only without the rock and roll? All right. With the rock and roll, without. Before I start, I always put my declarations of interest up, just to show that when it comes to the pharmaceutical industry, I am a bit of a tart. But I have to point out I'm not a prostitute. So if I do a talk for somebody, I never change anything I say just because somebody's asked me to do a talk. So I remain ferociously independent, shall we say. Howard asked me to do several different things, and we changed it fairly much at the last minute. So I just thought I'd start with the question, are mental health problems unpleasant but cause no real long-term damage? A yes or no? Oh. Yeah. Do they cause any long-term damage? Or can they? Yeah, I think most sort of, I'm hearing a whisper of yes. Is that about? Yeah. Okay, right. I just thought these are some of the risks of having untreated depression, just taking this as an example. You've got the potential for abusing drugs, which is much higher. You get cognitive impairment, so in other words, your ability to be able to think straight, to be able to make decisions, plan ahead, those types of things. They're all, sort of 15 out of 16 people with depression have those as major symptoms. And in fact, an awful lot of people still have those even when they've theoretically recovered. And every time you have an episode of depression, that gets worse. You get harm to your relationships, families, and so on, which was what I thought I was talking about on Monday with my one appearance on Mustard TV. Has anyone heard of Mustard TV? Yes, a few. Yes. I was on it on Monday. I managed to get Darren Eady to laugh so much we had to do a retake, which was very, very satisfying. I thought that was meant to be about that, but in fact it wasn't. But you've got the potential for poor work, it's difficult to work, you're irritable, you're absent, your productivity's not very good, which then has knock-on effects for your potential for future earning and so on. It's harder to overcome serious physical illness. You also suffer from more pain at the same time. You get poor sleep. You've got more chances of getting infections, particularly kidney infections and damage. You've got twice the chance of getting dementia later in life if you've had at least one major episode of depression, which partly is due to this thing here called hippocampal atrophy. Yeah, that's just me showing off, by the way, that I can say hippocampal atrophy. But your hippocampus is the part of the brain that's involved with learning things, laying down memory, spatial awareness, those sort of things. When you're depressed, your hippocampus shrinks. If it shrinks, that increases your chance of getting dementia later in life. So you've also got, it's harder to make health choices, you've got a higher chance of self-harming, suicidal ideation, and so on. And also, you've got any physical health conditions, then pain becomes more acute. That's quite interesting work looking at the fact if you're depressed, how much more difficult it is to recover from physical health conditions. Now, I just say this because depression, I'm trying to make a point that depression isn't just something that get over it and everything will be okay, because sometimes it can have quite devastating and significant long-term consequences. It's not a condition without any, it's not like having a headache for a couple of days or breaking your leg when it'll get better again. It's perhaps goes a bit deeper than that. I just chose two conditions at random, schizophrenia or psychosis, whichever you want to call it. Long-term effects of that can be pretty devastating as well, as I'm sure many of you will be aware of. First of all, you're suffering severely from a lot of symptoms long-term, which means it's difficult to work, difficult to get through education, difficult to make friends, keep friends. You've got a higher chance of getting diabetes, having high cholesterol, high fats, and so on, which is sometimes called the metabolic syndrome. If you take antipsychotics at the same time, that increases the risk again, but actually having a mental health problem, including diabetes, including bipolar and schizophrenia, you've got a much greater chance, even without any drugs, of getting diabetes and high cholesterol and so on. So it's not just the drugs that cause it, it's actually an additive effect. You're 2 to 3 times more likely to die at a younger age, and on average somebody with schizophrenia dies between 20 and 25 years younger than somebody else of equivalent age and status and so on. You're more likely to abuse substances, 8 times as likely to get epilepsy, twice as likely to have a chest infection or pneumonia and then die from it. So there's a lot of, major long-term consequences, and I could have gone through a whole load of conditions with long-term effects of them. Just going back to schizophrenia and to depression, what are the causes of them? Now, they might be psychological, whatever. However, it's worth bearing in mind that there are significant genetic factors involved in somebody developing depression or schizophrenia or some other conditions, not all of them. If you look at depression as an example, around 40, possibly to as many as 70%, well over, possibly at least half people with depression or suffer from depression have got a relative, a close relative who's had depression. And if you go through sort of depressive histories, you tend to find it tends to run more in families. So there's probably quite a good reason for that. So it strikes me that and even the sort of separation twin studies, the Scandinavian studies and other studies have shown that percentage chance is the same, is high, even if you've not been brought up in a sort of depressive household or whatever the phrase for that would be. And maybe part of that may be the ability to withstand stress, to be able to some people can take stress and it bounces off them. Some people are very vulnerable to stress. Some people need an amount of stress to be able to function properly. But stress has an effect on the brain and the way in which the brain cells can change and reconnect with each other. And if you've and that may be related to the fact that maybe genetically you don't produce enough, for instance, serotonin or something like that. We know that tryptophan, which is an amino acid, tryptophan is used by the body to make serotonin, which is one of the transmitters in the brain which regulates mood. Now, if you happen to be not a very good maker of serotonin, or you don't have enough tryptophan or something, or you don't have any at all, that may well take you over the limit, take you over a threshold, which then puts you in a point where you begin to feel depressed, and so it goes on from there. BDNF, I get very excited about BDNF. That's just me showing off, really, but it's brain-derived neurotrophic factor. Fascinating. If you're depressed, your BDNF levels go right down. And then when you get better, so they come back up again. All the different if you go and exercise, your BDNF levels, if you're depressed, BDNF levels go like that and then back down again. If you're ECT, they do the same thing. Other drug treatments, they gradually improve again. BDNF is the protective chemical in the brain. It's like giving soup to soldiers. It sort of helps them build them up, and it's very protective in the brain. It's fascinating what happens to BDNF during different conditions. But I'll shut up about that because it's very complicated and I don't understand it. That's the other thing. Now, okay, just taking schizophrenia again. If you've got an identical twin with schizophrenia, you're 46 times more likely to get schizophrenia or get a diagnosis of schizophrenia than anybody else of a similar age and background and so on. If both your parents have got schizophrenia, you've got a 40 times more chance of getting schizophrenia. A non-identical twin is 14 times more likely. One parent, 10 times more likely. Brother or sister, 10 times. If you have a child who develops schizophrenia, you're 5 times more likely. Now, if you look at that, the identical twin thing means there must be something in your genes which is making you vulnerable to a condition, because it's the genes that create the chromosomes have the genes which then create the way in which the brain structure is put together. And there's genetic links for loads and loads of different conditions, and there are for many mental health conditions. So now, which are the best treatments? I'll probably not open that one out too much. Because what I think the best treatments are is whatever helps you get on with your life. Whatever helps you get on with doing what you want to do is the best thing. And I think that actually it's a combination of three things is most likely to help people improve. You've got self-help, help from others, and often medication to help control the symptoms. And that's true of many mental health conditions. It's also true of many general medical conditions. So diabetes, insulin is vitally important. It can help control your blood sugar and so on. But actually you need to help yourself to look after what you eat and how you eat. And someone else needs to help you learn how to use insulin and what to eat and how to look after yourself. So actually it's the combinations of the three tends to be the best outcomes. And what I tend to think of it is it's a bit like a three-legged stool. You've got self-help, help from others, and medication. If you've got all three, that's fairly stable, isn't it? You can sit on that and you can get on with your life and it all looks, you're reasonably stable. If you take one of them away, then if you do it nice and gently, then you get used to it, you get settled, and you can probably be okay with two. You could have a wobble, and that might be a bit tricky. If you only have one leg, and you cannot believe how long it took me searching the internet to find a picture of a one-legged stool. And somebody did point out I should have had a shooting stick, actually, which would have been the best one. If you've only got one of them, that's fine. You might well be okay, but you're much more vulnerable to a wobble as such. So, but the important thing is, if you've got those three legs there, the one thing you don't want to do if you're nice and settled on a stool is to whip one of those away really quickly. So one of the points I was going to make is that whatever you do, whatever treatment you start or start everything slowly and stop things slowly. Let your brain get used to things. It's not a good idea if you're taking a medicine of some variety just to stop it like that. Let your brain get used to it, reduce the dose gradually, and then you're much more likely to be able to stabilize yourself rather than whipping something away really quickly. Now, as we all know, the brain's the most important organ we've got. Yeah, well, that is according to the brain. So there we are. So we've had some of these, haven't we? That's probably better, actually. It's a much more accurate view of the brain. I'll just let you take that in for a second. Well, camera now, pan up to the picture. Yes, if you can't see it from down here, that bit there says, footnote, the listening to children cry in the middle of the night gland is not shown due to its small and underdeveloped nature, best looked at under a microscope. But that's one way of looking at the brain. That's actually probably another way. Takes a second for that one. You just seen that, right. So anyway, let's just have a quick look at the brain itself, and I'll try and tie all these ends together. So there we are. That's a brain cell. We've got roughly about 10,000 million brain cells. Probably a few less than when we started the afternoon, but so it's got a nucleus in the middle. That's a cell body. That's blood vessels coming through. That's astrocytes, and that's a photobombing microglial cell. We don't know much about the brain and brain cells. Probably on a scale of 1 to 100, we've probably got to about 1 if we think hard about it. So we really don't know that much about the brain. We do know quite a bit about synapses, which is the junctions between one brain cell and another brain cell. But essentially, this has got fibers and filaments in it. Messages go out through this, up there, and they go off to another brain cell somewhere else. And at the end of there will be loads of synapses. So anyway, synapses are the important thing. We know quite a lot about synapses because they're very similar in humans. So a human synapse is actually very similar to a monkey synapse, which in structure is very similar to dogs, rats, toads, earthworms, you name it. Anything that's got a nervous system, synapses look pretty much the same. And how they work is that you've got a brain cell in Norwich, over there. It's sending a message down here, and it comes along a bit like an electrical Mexican wave. When it arrives there, you've got this synapse here. So in that area there, you've got these vesicles which contain small chemicals called chemical transmitters. You've got a gap, then you've got the next nerve which goes off to a brain cell down in Watton. Is that right? Is that right? So, yeah, that's Watton's that way, isn't it? Ish, yeah. Over in Watton. And that nerve cell there has got some receptors on the surface of it. So how it all works is that the impulse comes along, it reaches the end of the nerve. When it gets there, you'll see these vesicles fuse with that end plate. They release transmitter. It will just be one chemical that's released. So it might be serotonin or noradrenaline or adrenaline or dopamine or something like that. They hit, oh, sorry, where have I gone to? Yeah, they'll hit the receptors. As they hit the receptor changes shape. So the impulse is then passed on. As it changes shape, it causes a change inside that nerve ending. As it does that, that triggers off a chain reaction in here, and then the impulse carries along, goes off to our brain cell over in Watton. The transmitter bounces off the receptor. It's taken back up into the nerve ending, back into the vesicles, then the whole thing resets itself. That takes about 1/1000th of a second to occur. And if you think how fast you can really speak if you want to, think how many movements of your throat and your vocal cords you have to have. That gives you an idea about how quickly that can occur. So that's what we know happens normally. There are around probably 80 different chemicals which are known to be transmitters in the brain. These are some of the major ones. So dopamine is one of them, which has been mentioned already. We know that dopamine doesn't have a huge impact in the body itself, but in the brain it's got 4 major areas, one of which is involved with taking information in, processing it, deciding what's important, what's called salience, deciding what's important, and then deciding what to do about it. That area of the brain uses dopamine as a transmitter, and it's sorting the wheat out from the chaff. It's deciding what I need to take action about. I can, from here, I can see people coming in through the door over there. I know they're just coming in and out, and somebody else is coming back in now. It doesn't, I'm standing up here doing a presentation. It's an open session, so that's not a problem. If this was a closed thing where all the doors were closed and a load of people started coming in, my brain would start thinking, how do they manage to get in? And what's that bloke with a camera doing there looking at me? And those sort of things. So your brain decides what's important and what isn't important. And the fact people coming in and out wasn't important, so my brain didn't put any attention to it. But the point is, if you end up with too much dopamine or too little dopamine in different parts of the brain, that will cause symptoms which will then affect you in the way that you can think and the way that you can act. So, for instance, one of the areas of dopamine in the brain is involved with, it's called the extrapyramidal striatal system. It's the one that tells your muscles to relax. Now, that's the bit of the brain that looks after that. Can go wrong sometimes. It can deteriorate. And that's what is the cause of, for instance, the symptoms of Parkinson's disease, or the cause of Parkinson's disease. If you don't have enough dopamine, if the substantia nigra degenerates, once you get down to about 1/5 or 1/10 of what you normally have, there's not enough dopamine, there's not enough messages going to your muscles, so your muscles tighten up, and that's where the tremor comes from, and I presume we're all familiar with Parkinson's disease? Yeah, see, you've got the tremor, you've got the stiffness. That's because the muscles won't relax. There's not enough dopamine. So what do we do? Really, there aren't any treatments as such for Parkinson's disease, but what you can do is take things like levodopa or bromocriptine, those sort of things, which stimulate dopamine. So therefore, they increase the amount of dopamine, It increases your body's ability to tell your muscles to relax, and therefore that relaxes the muscles, and therefore you can move around a bit easier. So you can see too much or too little dopamine in different areas can have an effect on you. If you look at serotonin, for instance, lots of different areas of serotonin in the brain, and those are the areas of the brain that cope with your sleep-wake cycle, regulates your mood, how happy you are with eating something, how satisfied you are with eating something. It can affect the way in which you react to things, so it can affect aggression. It affects your memory as well to an extent. And what we know is if we have too little or too much serotonin in areas of the brain, that will again cause symptoms. So if you've not got enough serotonin in the areas that are regulating your mood, you've essentially not got enough mood. So your mood goes down, and that's the beginning of depression, because you haven't got enough. We know that a lack of serotonin will cause your mood to drop. For instance, I could get everybody in this room depressed in 24 hours. I've got two options, one of which I could carry on talking. Ha ha ha. The other one is if I put you on a diet that contained all amino acids except tryptophan, your body would think, okay, I'm having a normal diet, and it wouldn't realise that it hadn't got enough tryptophan. And what would happen over the next 24 hours is that you would run out of serotonin, because tryptophan is made to replace serotonin all the time. And as a result of that, we would all be depressed in about 24 hours. We'd also all smell horrifically of fish, because the tryptophan depletion diet is horrible. Don't worry, you can't do it accidentally. But it is pretty horrible, but it can be done. So you can actually create depression in people without depression just by sucking the serotonin out of them. So it must be something to do with it. If you've got too much of it, then that affects the way in which you're happy with what you've eaten, and actually that can cause nausea. Noradrenaline, just deal with that briefly. Noradrenaline, that's the fight and flight. So that if you suddenly need to run away very quickly from somewhere, you have a sudden burst of adrenaline which affects your body so you can run faster and so on. But also, it'll affect noradrenaline in the brain, and that's involved with alertness, decision-making, again, mood and things like that. So if you've not got enough noradrenaline, you essentially haven't got enough mood. So your mood will drop. So we know that not enough serotonin and noradrenaline will reduce your mood. That's not necessarily, obviously it's not necessarily the whole answer, but we know that imbalances of chemicals, we know that imbalances of chemicals in the brain will cause symptoms. So, going through depression, we've got our normal transmission, ticking along like that. Now what we know in depression is there's not quite enough that serotonin and noradrenaline activity seem to be reduced. Now, what causes that, we really don't know, but we know the net end effect is there's not enough serotonin or noradrenaline effect, which will then lower your mood. And what most of the antidepressants do, certainly the major ones, is that they block this reuptake back into the nerve ending. So that when the next impulse comes along, you've not got that, you've still got some transmitter left in that nerve endings. So, new message comes along, transmitter's released, it joins the bit that's already there, and therefore you get more receptors hit, so you get a stronger message that's being passed, and that seems to be what helps the symptoms of depression. It's not curing it, but at least it's helping reduce the symptoms caused by there being not enough serotonin, which then hopefully will give somebody the ability to be able to cope with everything and get on with their lives. Now, this is a little bit experimental, but I'll just try and do this for you. If you're under stress, how you deal with it will depend on your thinking style, your cognitive style. However, if you are under stress or you've had a life event, ignore the long words or the initials, but that affects the hypopituitary adrenal axis, the HPA axis. That releases corticotrophin releasing factor, which stimulates adrenocorticotrophin. It's good, isn't it? You're all taking notes? No. Which stimulates the adrenal gland, which we do know well about. And if you produce cortisol, that suppresses the release of serotonin and noradrenaline. If you've not got enough serotonin and noradrenaline, it reduces your mood. If your mood's reduced, you're less able to cope with stress and life events and things that are going on. And so it goes round and round in circles, getting worse and worse and worse. And I do get a bit frustrated with sometimes the arguments about drugs are better and talking therapies are better and so on. If you actually look at this, yeah, drugs are helping that bit, and talking therapies are you generally helping that bit. So actually, rather than one being different from another, they're often complementary to each other, and they're going to helping different parts of this vicious circle that keeps on going around. And if you can cope with only that, fine. If you can cope with that, only fine. That's great. It doesn't really matter as long as it works and helps you get on with your life. So that's depression. Now, antipsychotics, having dealt with them previously, I mentioned there are 4 areas in the brain of dopamine. There's the mesolimbic, the mesocortical, the tuberoinfundibular system, and the striatal system. I'm on fire today, aren't I, at least? I should have stopped while I was going, was good, shouldn't I, really? Tuberoinfundibular system. That's great. It's taken me years to learn that, you know. I was hoping for a round of applause. So there are 4 areas of the brain that, if you joined up the dots, would all use dopamine as their transmitter. What we do know is that the mesolimbic system is to do with emotions and putting importance on things. The nigrostriatal one, that's the one that goes wrong in Parkinson's disease. So that's affecting your muscle tone and your muscle regulation. What's the next one then? Tuberoinfundibular, that controls the release of prolactin, which is a hormone that's mainly known for its effect in women. And your prolactin goes up. If you've got high prolactin, that happens after childbirth and before childbirth, so that tends to lead to milk production and stopping periods and those sort of things. But it has lots of other effects other than that. And then the mesocortical, the other bit, is to do with memory, learning, reward, and so on. So that's where your pleasure centres are. But what we know is if you've got too much dopamine in that area, then that's where you can produce hallucinations and delusions and so on. As an example, I was talking to somebody earlier about this. When you're Parkinson's disease, one of the things we can do is give people drugs which increase dopamine in this nigrostriatal pathway, and that increases the amount of dopamine, which means you've got the ability to relax your muscles. Now, if you go through all the books and look at the side effects of the drugs that increase dopamine, you'll find a lot of their side effects are things like psychosis, delusions, hallucinations, because those drugs are increasing dopamine in the bit we want, which is there. However, what they can do is increase them up here as well. And therefore, you're getting more dopamine in that area of the brain, which then means you've got more chance of getting psychosis and all the symptoms you get from psychosis and schizophrenia. If you were to, for instance, go out after this and smoke an enormous joint of cannabis, that's only hypothetical, it's not a suggestion that you do that. If you did, cannabis contains tetrahydrocannabinol. That stimulates cannabis receptors in the brain. I don't know if you knew we had cannabis receptors in the brain. No? But we do. Nobody's really found out what they're doing there, though. That's waiting for someone to discover cannabis. But if you stimulate cannabis receptors, it releases dopamine in this area. That's where the reward comes. That's why people smoke cannabis. However, if you get a bit of extra dopamine in there, sometimes it can spread to over here, and so you can sometimes get psychotic if you smoke cannabis. some people do, if you have a large amount of it, almost anybody could become psychotic. So you can see an excess of dopamine in different areas or a lack of dopamine in different areas will make a huge difference to the way the brain operates. Forget that one. Right, so if we look at psychosis, for instance, we've got impulse is sent, it arrives, transmitter is released, stimulated, so we got that. Now, so if you've got too much of it, as again somebody said to me earlier, why can't we just block the receptors? Well, actually, that's what all antipsychotics do. The one thing they've all got in common is they all block dopamine receptors. It's a bit like putting the wrong Yale key into a Yale lock. You can get it in, you can't get it out again, and it won't open the door or stimulate it. So what you're doing with antipsychotics is blocking some of the dopamine receptors, and therefore you're reducing the effect of there being too much dopamine, and too much dopamine is what causes the psychosis. Is this making sense, by the way, at the moment? There's a few nods. Yeah, that's all right. I'll carry on anyway. So that's what all antipsychotics have in common. They'll do lots of other things as well, because the shape of the molecule, they may well affect other transmitters. So in the brain, diazepam, Valium, lorazepam, temazepam, those sort of things, even the Z hypnotics like zopiclone and zolpidem and so on. That's the receptor that they work at, which is brilliant, because when I was a student, people said, well, we know there are receptors, but we'd never be able to see one. Now you can actually see one. That's what it looks like in diagrammatic form. I don't worry about that too much. But basically what happens is that GABA, one of the other transmitters in the brain, is the one that calms the brain down. So what can happen if GABA is released, it hits these transmitters, and that message there calms the brain down. However, if it doesn't calm it down enough, then you can be very anxious, you can have seizures, you can not get to sleep because the brain's still buzzing away. And what the benzodiazepines do, so lorazepam, diazepam, chlordiazepam epoxide, what other ones are there? Temazepam, nitrazepam, what? Clonazepam, yeah. Anything else that sounds anything like that probably is. What they do is they block that GABA in. So they jam it in place, keeps that open, and therefore it increases the amount of GABA, so it increases the amount of calming there is within the brain. And that's basically how they work. In fact, if you actually looked at the effect of caffeine, there's nothing wrong with caffeine. It's how I treat my mild ADHD. But caffeine works in a similar way. It prevents the sort of the calming occurring. So that's basically how. So the conclusion from that is that nearly all these drugs are affecting synapses, they're affecting transmitters, they're affecting the way in which brain cells communicate with each other. It's relatively crude, but what it is doing is helping to reduce the symptoms, and if that then allows you to get on with other therapies with the symptoms low enough, then that's what we're aiming at. So trying to tie all this together, that's all very well. We know what drugs do and know there are problems, but do medicines actually work? This is a little bit random, but I'll try and... this is a social anxiety. I've been trying to get this information together for some time, and I've got it for some conditions, but not all of them yet. But if we take social anxiety as an example, if you assume that everybody who enters a clinical trial has got loads of symptoms, so nobody is symptom-free, these are approximate figures, but roughly with the antidepressants, and as was said earlier, antidepressants is a terrible, terrible term because they do lots of different things. But roughly 50% of people will have no symptoms after 12 weeks and 80% after about 6 months. If you have a placebo, it's about 35%. Because that's always an interesting thing about placebo response. If placebos were that great, why don't we just have placebos? Because placebos only work if you think they're going to work. So if I give everybody here a drug and say, this is going to turn your hair green, you go, no, it isn't. Whereas if I say this is going to cure your depression, if I'd done that 50 years ago, you get a very low placebo response. If you say that now, because there are antidepressants available which do work, then your expectation of a response is that much higher. So that's your placebo responses are higher. It's been an interesting thing that placebo response has got higher over the years. And part of that is because there are more drugs which work. Group CBT, 45%, 50%. Phenylxenone, group CBT. So when it comes to it, I mean, those are only approximate figures. I haven't really got this sort of the range that they are. But you can see that the different treatments are having different effects. They are working for some people, not for others. So it's a matter of finding which one's best for you. ADHD, which is one of my special areas of interest, that you can see the response for stimulants for ADHD is it's around the sort of the 70 to 80% mark in terms of people losing the disruptive symptoms of ADHD. And in fact, most of those treatments are pretty much the same as each other. However, you can't really see that. But the last line is nothing at all. So you put people in a trial and you give some of them a drug, and the rest of them you say, we're just not going to treat you. If you give people nothing at all, the symptoms do not improve. Going on to depression, this is even more difficult to get the correct data for this. But it does look like, the figures are around. You still get a placebo response, but you get a better response with antidepressants. They're still not marvelous. There's still lots of people who don't respond. But the trouble is the human brain, everyone's brains are individual. It's really irritating, actually. If they were all the same, we'd find treatments that work. Never mind. So that's just the sort. I've just been trying to put all these figures together. It's quite difficult to put talking therapies in here because they're not the same types of trials as drug trials. Because most of the psychological therapy trials use what's called waiting list controls. Waiting list controls means you get a load of people. One of them you say we're going to treat you. The rest of them you say we know you're ill, but we're not going to treat you. Now, that would never be allowed in a drug trial. You'd have to have an exact matching placebo, exact matching thing, and everything else would have to be the same rather than we're just not going to treat you. So that's quite difficult to do. So you can see from that, essentially, that, yes, the drugs are having more of an effect than placebo or nothing at all. And in the case of antidepressants, I just found this early today, actually, which is just nicked this one in. Antidepressants work better the more depressed you are. So that's the response to placebo, depending how depressed you are, and that's the effect of antidepressants. So the more depressed you get, the more effective antidepressants are. Now, I'm just about running out of time. So NNTs is something that probably most people wouldn't be terribly interested in. Just that it's essentially the number of people you need to treat to get a response or to get somebody better compared to having no treatment at all. Now, what you need to know is anything in single figures is actually considered pretty reasonable. So any treatment that gives you an NNT of less than about 8, I suppose, 8 or 9, is considered to be a good treatment. And NICE uses this as their criteria as well. So, for instance, if you have a steroid injection for tennis elbow, it's an NNT of 4, which I think tends to belie the fact that actually it's quite good, really, in that respect. People I know who've ever had that type of treatment. If you take an aspirin to prevent stroke, then that's an NNT of 102. That's quite acceptable because aspirin's cheap and doesn't really have many side effects at the dose you need. So although you've got to treat 100 people to stop a stroke, the remaining 99 don't really have any side effects. So it's actually a very low risk strategy. Now, I've got 2 missing from there, one of which is ADHD and one of which is depression. The ADHD, Actually 1.1 for treatment of ADHD in prisons, which is astonishing. But the other thing, I just want to point out that in terms of preventing relapse of depression, antidepressants are actually very, very effective. It's probably their major effect is in preventing relapse of depression, as well as treating it, but actually their major thing is actually preventing relapse. An NNT of just over 4, that is pretty good. It's as good as most treatments. So to tie all this together, I'll just quote Kay Redfield Jameson. I don't know if any of you heard of her, a famous psychologist from Pittsburgh, professor, suffered from bipolar throughout for nearly all of her life, produced vast amounts of fantastic work when she was high, been really seriously ill. She's on lithium, and what she said was, I rather like this, was lithium controls my symptoms, therapy helps me live with it. And I just thought that was actually a really good way of putting different therapies into perspective, because they help her. I mean, she's a psychologist, so she's tried coming off lithium quite a few times and not succeeded. So in the conclusion, I would say that many mental health problems have known chemical imbalances. We don't know whether they're the cause or effect. I'm sure it's actually it's the cause of the symptoms, but we don't know what's caused that. There are lots of ways to deal with those. If regular medication, rather than messing around with them, is a good way to deal with that for many people, and much reduces your chances of becoming unwell again. They often help talking therapies to work and vice versa. And if it helps keep you alive and functioning and getting on with your life, I don't see what the problem is, really. And I'll just finish off by saying, if you want any information as well, this is most of our pharmacy stuff that we do within the Trust. We have a telephone helpline, Norwich 421 212. We've also got our choice of medication website. So if you go to the front page of the Trust, website, so that's nsft.nhs.uk. You then go to Find Help, which is there. That's in the wrong place. It should be just down there. Learn more about medication is there. Click on that, takes you through to that website. You can there are 22 conditions with at least 15 questions on each condition. 155 drugs with 30 questions and answers on each of those. They're all the questions and answers that people want to know rather than what I've decided you want to know. So that's the thing, you can click on one of those questions and look at that. It's quite in-depth, but hopefully quite readable. Under the main options for treatment, for instance, it's got main medications, self-help, help from others, and then medications is a separate section, which is what that is. If you click on any of those drugs, if you click on, for instance, fluoxetine, it takes you through to the questions and answers on fluoxetine. There are leaflets you can print out, so 2-page leaflets, 2-page easy read leaflets. If you've got a Lithuanian reader, anybody, we've got Lithuanian, Polish, Urdu, got loads of different languages on there as well as translations. There are fact sheets. I was talking to somebody earlier about, there's one on deciding whether you want to come off medication. So there's loads of different leaflets on there, plus our handy charts, which we've got some books out on there. So that's all there. It's free access via the Trust website. And I would just finish by saying, whatever you do, always give 100%, unless you're donating blood.